Welcome to the theory on acute inflammation. Following topics are dealt with in this video. What comes to your mind when you think of the term inflammation? It is the body defense response, in order to eliminate or limit the spread of injurious agent, followed by removal of the necrosed cells and tissues and to initiate the process of repair. So it is not just the body response but also involves the process of healing. Another word that it can be confused with is infection. Remember, infection means invasion into the body by harmful microbes and their ill effects. The way body responds to them is inflammation, and infection is only one cause that triggers inflammation. Coming to the important, or cardinal signs, which are observed when an inflammation is in process inside the body. They are calor or heat, that is, raised temperature, rubor or redness. Tumor or swelling. Dolor means pain. Functio lesa, which implies loss of function in that area. So these features mean that an area which is inflamed shows the sign of raised temperature, with redness, swelling and pain, or tenderness. A loss of function or decreased activity occurs. The term actually means burning, but that is of course only one feature of inflammation. These signs occur due to underlying vascular changes and immune system activation. Inflammation can be of two types: acute and chronic. Acute inflammation is what we will be dealing with in detail in this video. Inflammation becomes chronic if the triggering agent continues to persist in small numbers, despite the initial inflammatory response. As for example, if infective agent of pneumonia is not cleared completely, it can lead to lung abscess. Second cause of chronic inflammation is recurrent attacks of acute inflammation. Just like recurrent attacks of recurrent UTI, even after treatment can lead to chronic pyelonephritis. Sometimes, it can start directly without passing through the phase of acute inflammation. This usually occurs when infection occurs with microbes of low pathogenicity, like Mycobacterium tuberculosis. As the name implies, acute inflammation starts immediately, usually within minutes to maximum up to hours. While chronic inflammation is slower to begin and takes days to start. The main type of immune cells seen with acute inflammation is neutrophils. While lymphocytes, mast cells or macrophages, are the main cells in chronic inflammation. Acute inflammation is usually mild and self-limited, but chronic inflammation is usually severe and progresses gradually. Local and systemic manifestation like pain, fever, etc. are more prominent in acute than in chronic. The basic steps of acute inflammation can be remembered as 5R: recognition of the injurious agent, recruitment of leucocytes, removal of the agent, regulation of the response and repair. We will be seeing them in details in the rest of this video. So let's begin with the details of acute inflammation now. Among the agents that trigger acute inflammation, infection with different microbes is the most common. Other causes include physical and chemical agents, like trauma, burn, frostbite, heat, radiation. Foreign bodies like a pacemaker can also trigger inflammation. Immunological triggers, which lead to immune-mediated inflammatory reactions or most commonly called hypersensitivity reactions. Here the trigger could be an environmental substances or self-tissues. Starting with first R, which stands for recognition of inciting agent. So, the question is, how do the inflammatory cell recognize the agents? It is via the pattern recognition receptors. These receptors are present on the immune or inflammatory cells. These receptors recognize the pattern-associated molecular patterns, which are present on the microbes as well as other inciting agents. Similarly, they can also recognize the damage-associated molecular pattern or DAMP, which are present on the host's dying, damaged cells, so that a process of repair can be started. The main events which leads to the process of inflammation include the vascular changes first, followed by cellular changes. They are responsible for second and third Rs. Hemodynamic changes followed by increased permeability of microvasculature occur, so that lymphocytes can reach the site of inflammation. And hence, accomplish our second R, which was recruitment of lymphocyte. Starting with hemodynamic changes, the very first change encountered is a transient vasoconstriction, which lasts only for 3 to 5 seconds to a maximum of 5 minutes. And involves mainly the arterioles. This is followed by a persistent and progressive vasodilation. The effect is seen within 30 minutes and it is responsible for the redness and raised temperature. Increased blood flow along with raised vascular permeability also leads to movement of intravascular fluid outside the vessels and leads to third cardinal feature of swelling. As fluid oozes out, blood becomes more concentrated. and this causes slowing or stasis of blood flow within the vessels. The smaller, faster RBC pushes the larger WBC to the peripheries. Thus, the leukocytes come closer to begin to the vessel's endothelial surface. This is called margination. Causes of increased vascular permeability includes endothelial cells contractions, endothelial cells injury, transcytosis of proteins, and leakage from new blood vessels. Endothelial cell contraction is the most common, and affects mainly the venules. It is reversible and usually short-lived, most importantly seen in conditions like mild burns. Under the influence of cytokines like histamine, bradykinin and leukotrienes, endothelial cells begin to contract due to cytoskeletal changes, creating gaps for the fluid to escape. Endothelial cell injury occurs due to necrosis and detachment of endothelial cells. All microvasculature can be affected. The effect lasts for several hours or days. This mechanism is more importantly seen in moderate burn, bacterial toxins, or UV injury. Activated leukocytes release toxins, which causes the injury. Transcytosis of protein can occur under the influence of mediators as VEGF. Protein is transported via channels formed by fusion of intracellular vesicles. Angiogenesis occurs during repair. These new blood vessels are leaky until endothelial cells mature to form intercellular junctions. Now coming to the cellular level of the events that take place, which finally had to complete the second and the third are first, leukocytes exudate out of blood vessels to reach the site and then get activated to kill and degrade the harmful agents. Let's see how it actually happens. Beginning with exudation of leukocytes, which is the most important. Senses acute inflammation. Neutrophils are the most important leukocytes, followed by monocytes or macrophages. Leukocytes migrate in 4 steps. Margination, rolling and adhesion, transmigration, and lastly, chemotaxis. Margination brings the leukocytes closer to the endothelial cells and has already been discussed in the vascular events. Then the process of rolling and adhesion begins. Under the effect of cytokines and other mediators, endothelium express adhesion molecule. Respective receptors are present on leukocytes. Leukocytes which have already come closer to endothelial cells form temporary loose bond, and since the bind is loose, they detach again, and this process of attachment and detachment continues, causing the leukocytes to roll over the endothelial surface. This process is called rolling. Process of rolling and cytokine release and then activates integrins receptors, which cause firm attachment of leukocyte to the endothelium, and leukocytes no longer roll away from endothelium. This process is called adhesion. Process of rolling is mediated by selectins, which are expressed on leukocytes and endothelium. These are of 3 types: P-selectin, E-selectin, and L-selectin. P-selectins are preformed and stored in endothelial cells and platelets. We can remember P for preformed and platelet. Since these are already formed, they come immediately into action. They cause leukocytes to bind but only cause loose adhesion. E-selectins, which are also known as ECAM or endothelial cell adhesion molecule, are formed once endothelial cells are activated by cytokines like interleukin-1 and tumor necrosis factor. This receptor forms slightly tighter bond than P-selectins, but cells still don't adhere and continue to roll. L-selectins receptor cause rolling in lymph nodes. It can be remembered as L for lymph nodes. Process of addition is mediated by integrin receptors, which are normally expressed on leukocyte plasma membranes in a low affinity form. They are activated by chemokines. They cause leukocytes to get tightly attached to endothelium. Once attached to the endothelium tightly, leukocytes find the junction between the endothelial cells and throw out pseudopods to help them squeeze out. The process of squeezing out is called diapedesis. Collagenase, then, helps by damaging the basement membrane of endothelium, so that leukocytes can finally escape out of the blood vessel. The process of migration of leukocyte out of blood vessel into extravascular space is called transmigration. Then the leukocytes reach the site of inflammation via a chemical gradient through a process called chemotaxis. This is facilitated by exogenous and endogenous substances like bacterial products, cytokines, components of the complement system, products of the lipoxygenase pathway of arachidonic acid metabolism. Leukocytes extend pseudopods, and anchor themselves to the extracellular matrix, and then pull themselves in the direction of the extension. Once leukocytes exudate out, and second R or recruitment occurs, leukocytes are activated to fulfill the third R or killing and degradation of agents. Stimuli for leukocyte activation include microbes, products of necrotic cells and other mediators. Once activated, following take place: phagocytosis, killing and degradation, and production of mediators. Phagocytosis is the process of engulfment of solid particulate material by the cells. Phagocytes are the cells which perform phagocytosis like neutrophils, monocytes or macrophage. Steps involved in phagocytosis are recognition and attachment, engulfment, and finally, killing and degradation. Recognition and attachment occur by means of specific surface receptors. Opsonins coat microbes and target them for phagocytosis. This process is called opsonization. Opsonization means preparing to eat, as opsonization helps forming bond between microbes and membrane of phagocytes. Few examples of opsonins include Fc fragment of IgG breakdown products of the complement protein C3. Plasma carbohydrate binding lectins. Once agents are recognized, leucocytes begin to engulf them by throwing and capturing them inside pseudopods, to form what is called phagocytic vacuole or phagosome. This phagosome breaks away from cell membrane to move inside. Inside the cell, it fuses with lysosome to form phagolysosome. Granules inside lysosomes discharge to help in further killing and degrading process. Killing and degradation can occur not only within the inflammatory cells but also extracellularly. Intracellularly it occurs by oxidative mechanisms using oxygen-free radical or with the help of lysosomal granules, or via various non-oxidative mechanisms. Extracellularly, killing and degradation involves immune mechanisms, discharge from lysosomal granules, or neutrophil extracellular traps. Let's have a quick look into them. Intracellular oxidative mechanisms are the most important. An oxidative or respiratory burst starts with the phagocytosis or stimulation of various receptors. Reactive oxygen metabolites are particularly useful in eliminating microbial organisms that grow within phagocytes like Mycobacterium tuberculosis. Production of oxygen radicals occur by the help of NADPH oxidase or phagocyte oxidase. The generation of the oxygen metabolites is due to rapid activation of a leucocyte NADPH oxidase, called the phagocyte oxidase, which oxidizes NADPH and, in the process, converts oxygen to superoxide ion. Superoxide is then converted to hydrogen peroxide. These free radicals can destroy microbes. The lysosomes of neutrophils, called azurophilic granules, have myeloperoxidase, which converts H2O2 to hypochlorous radical. This hypochlorous radical is a powerful oxidant and antimicrobial agent. Mature macrophages lack myeloperoxidase. They produce hydroxyl ions from H2O2 by Haber-Weiss or Fenton reaction. Lysosomal granules contain various products which are discharged within the phagosome or extracellularly, like myeloperoxidase, protease, trypsinase, phospholipase, and alkaline phosphatase. Some processes do not involve oxygen. These include some of lysosomal granules release preformed enzymes like lysosomal hydrolases, permeability increasing factors, cationic protein, lipases, proteases, DNases. Nitric oxide is another potent killer, produced by endothelial cells and activated macrophages, with the help of nitric oxide synthase. Product from granules, discussed earlier, have effect extracellularly, as well. Immune-mediated lysis of microbes occurs extracellularly, by cytolysis, antibody-mediated lysis and by cell-mediated cytotoxicity. Another interesting mechanism is formation of neutrophil extracellular traps or NET. These are extracellular fibrillar networks produced by neutrophils. They contain high concentration of antimicrobial substances and prevent the spread of the harmful agents by trapping them within the web. Balance needs to be maintained between the pro-inflammatory and the anti-inflammatory mediators, so that, as the inflammatory process agent it is removed, the body can get back to its normal and less number of normal cells are damaged. This is the fourth R, or the regulation of inflammation. Inflammation begins to subside as the mediators are short-lived and are destroyed by degradative enzymes. Some anti-inflammatory mediators like lipoxins and complement regulatory proteins also help to bring inflammatory process in control. Activated macrophages and other cells secrete interleukin-10, which down-regulates the effect of activated macrophages. Another important cytokine is include TGF-beta, which is a mediator of fibrosis in the process of tissue repair. Antioxidant, like ceruloplasmin, helps in removing excessive free oxygen radicals. Stress protein like heat shock protein are chaperones that carry the toxic waste within the cell to the lysosome. An important body hormone, glucocorticoid, also suppress the inflammatory process. Prostaglandin E2 can act both as a pro-inflammatory as well and an anti-inflammatory mediator. These were only few examples of regulatory mechanisms. Let's proceed to the outcome of acute inflammation. An acute inflammation can lead to what it was aimed for, which is the removal of harmful agent from our body. Sometimes, there may be no tissue loss during this process and body returns to its normal structural and functional state, with the resolution of inflammatory process. When there is tissue loss, a process of repair or healing starts with the process of regeneration or scar formations. Regeneration occurs when tissues are able to replace the damaged cells and return to the normal state. It occurs by proliferation of remaining cells which have the capacity to divide, and by replacement from stem cells. Another method of healing is by scar formation. This takes place when the injured tissues cannot regenerate, or if the supporting structures of the tissue are severely damaged. Connective or fibrous tissues are laid down and this results in scar formation. The fibrous scar cannot perform the function of lost parenchymal cells. It provides enough structural stability that the injured tissue is usually able to function. This concludes the fifth R of acute inflammation, or repair. Third outcome is chronic inflammation, which occurs if the inciting agent was not removed completely. Sometimes, an agent can cause a chronic inflammation from the very beginning, as in some viral infections or autoimmune diseases. This video. Stay tuned for more. You can also watch the 3D video on inflammation.